Hello, everyone, and welcome to today's webinar, Recurrent Pregnancy Loss, featuring Dr. Kristi Maas from the Reproductive Care Center. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Kristi Maas is double board certified in reproductive endocrinology and obstetrics and gynecology, and sees patients at Reproductive Care Center in Sandy, Utah. Dr. Maas earned an honors Bachelor's of Science and Master's of Engineering in Biomedical Engineering, and her Doctorate of Medicine, all from the University of Utah. She completed a 4-year residency in obstetrics and gynecology at Maine Medical Center and Tufts University School of Medicine. Dr. Maas completed a 3-year fellowship in reproductive endocrinology and infertility at Beth Israel Deaconess Medical Center, Boston IVF, Harvard Medical School. Dr. Maas loves working with patients to tailor care to each individual's case and uses her diverse experiences to meticulously plan treatment. She feels that all patients should have access to care regardless of location or background. All right, we're about to get started. I'm going to pass it over to Dr. Maas.
Thank you, everybody, for logging in today. I'm excited to talk to you about recurrent pregnancy loss, which is one of the hardest topics that I work through with patients. These patients have often struggled to try and achieve their pregnancy, maintain their pregnancy. They're dealing with the emotional component of losing a pregnancy, losing the future that they had hoped for this child. And then also there's a lot of self-blame involved. And as care providers, we really need to help them remove the stigma and try and understand the potential underlying causes and how we can best treat them and support them. Without further ado, let's talk a little bit about some of the components. I have nothing to disclose as far as conflicts of interest. Females have a finite egg supply. We're born with every egg that we will ever have. And by the time we hit puberty, we're down to about 600,000 eggs. And by our mid-reproductive years, we're down to about 25,000 eggs. Now with this, we're declining not only in quantity of eggs, but also quality of eggs. And quality is what we define as genetic normality and metabolic competency. And it's this quality that is the strongest determining factor of reproductive outcomes or fertility. And here we see that fertility declines gradually in our 20s and early 30s, and then much more readily when we get to our mid to late 30s and early 40s. And we generally ovulate 1 egg a month, whether we're 20, 30, or 40. It's just much more likely that the egg is reproductively competent, meaning genetically normal, and metabolically functional when we're 20 versus 30 versus 40. With fertility, most people achieve a pregnancy within the first 12 months of trying, and that's where we get our definition of infertility, meaning not achieving a pregnancy. Recurrent pregnancy loss and infertility are 2 very discrete problems. Some people get pregnant very easily, but they struggle to maintain pregnancy. Other people struggle to get pregnant, but once they get pregnant, they stay pregnant. That's infertility. And then we also have this unique population of overlap where patients struggle not only to get pregnant, but also to stay pregnant. Our miscarriage rates do go up significantly with egg age, and that's primarily because of oocyte aneuploid or genetic abnormality that is due to ovarian aging. Pregnancy loss is estimated to be approximately 15 to 25% of pregnancies. When we talk about ovarian aging, one of the most important components is that oocyte aneuploidy increases. We have to divide our gametes so that we are haploid at the time of fertilization instead of diploid. And when we talk about having things align on the metaphase plate, and the spindle becomes less functional, and we oftentimes grab an extra chromosome or leave a chromosome behind as we're aligning along the metaphase plate. And this is what contributes significantly to oocyte aneuploidy and is the strongest factor for determining pregnancy rates and miscarriage rates. Because egg aging is an ongoing process, the maternal age is a major contributing factor to our miscarriage rates and our number of miscarriages. So this is a graph that categorizes the number of losses by age of the egg source. And we see that as we increase in age, the number of miscarriages is going to increase significantly because of that oocyte aneuploidy. Interestingly, patients with recurrent pregnancy loss tend to actually have a lower aneuploidy rate because there's other contributing factors beyond just egg aneuploidy. Our most common aneuploidies are trisomies, and we see trisomy 16. So for those of you OBGYNs who are doing D&Cs for retained products or missed abortions, we very commonly see trisomy 16 on products of conception. About 22% of losses are due to polyploidy. About 19% are due to monosomy X, also known as Turner syndrome. We can have sex chromosome imbalances, that's Klinefelter's, that's the super Ys, the trisomy X. And we see most aneuploid losses early on. Most of these are not compatible with life or long-term viability or long-term gestation. 70 to 80% occurring within the first 4 to 7 weeks. So I'm seeing these much more commonly. General OBGYNs, you may not see these as frequently because patients often have not even entered into care by the time they have losses. And that's some of the limitation for trying to get additional information when we're talking about the definition, the treatment, and the assessment of recurrent pregnancy loss if people are entering into care a little bit later on. The definition of recurrent pregnancy loss by the American Society for Reproductive Medicine is 2 or more clinical losses prior to the 20th week of gestation. And when we're defining a clinical pregnancy loss, we're defining that by either ultrasound demonstration of a pregnancy within the uterus or by histopathologic assessment from tissue assessment. If it's a pregnancy of unclear location, if it's an ectopic pregnancy or a biochemical pregnancy, those actually do not meet formal definition for recurrent pregnancy loss. If we think about general patients with miscarriages, as I mentioned before, miscarriage unfortunately is quite common, but having 2 miscarriages is infrequent. Less than 5% of patients experience 2 miscarriages, and less than 1% will experience 3 or more losses. And so when we get into multiple losses, this is where someone has aberrant findings and we need to start investigating and digging deeper to try and get some answers. Things that we should take, of course, everything, all the board's answers, comprehensive history and physical examination. So first component, maternal age. We talked about oocyte aneuploidy being the strongest determining factor for fertility and a significant risk factor for miscarriage. We also want to know the gestational age of the losses. Are they early losses? Are they second trimester losses, third trimester losses? We want to make sure that we're taking an extensive pregnancy obstetric history. How long did it take you to get pregnant? When did you see a care provider for your first visit? Was it, hey, you're entering into care in the second trimester and something happened in the first that we couldn't tell what was going on because you're late to care? Or is it early established pregnancy with a clinical intrauterine pregnancy loss? It's helpful to know whether or not there have been any successful pregnancies that have resulted in live birth, because that can help delineate some of our risk factors. Was any type of procedure performed, a D&C or a D&E, and have we gotten a fetal karyotype from the products of conception? Aneuploid losses are thought of very differently than euploid losses. An aneuploid loss can be a natural selection process where something implanted that is not compatible with long-term life or viability, whereas a euploid loss is atypical and warrants further investigation. We also want to take a comprehensive family history. Did mom and mom's mom all have multiple miscarriages, or is there a history of term fetal demise or other complications? Unfortunately, recurrent miscarriage is primarily unexplained. So greater than half of our miscarriages that are recurrent are in an unexplained category. Then we have other, autoimmune, anatomic or uterine factors, and genetic factors being the smallest component, which is why this is such a tricky subject. This all happens in the black box of the pelvic anatomy, which is really hard to test ex vivo because so many things are occurring that we don't fully know, understand, or have the ability to test. If we go to the ASRM practice bulletin that gives us guidance on what type of factors may be contributing to recurrent pregnancy loss, and what testing should be done, we're going to start with the cytogenetic testing. This is because that significant proportion of aneuploid loss or genetic causes. So we're going to start looking at karyotypes. I mentioned karyotypes on products of conception, and certainly this can raise red flags if we're seeing translocations there, or if we're seeing recurrent aneuploidy that is consistent from loss to loss. But we know that we want to do parental karyotypes. We need to test the sperm source and the egg source. And we're looking for balanced translocations, which occur in 2 to 5%, Robertsonian translocations, chromosomal inversions less commonly, or ring chromosomes, and 3 to 8% of couples with recurrent loss will have some sort of chromosomal rearrangement in one partner. A reciprocal translocation, going back to basic genetics and med school for some of you, is the last time you've thought about this, but that's where part of one chromosome is essentially flip-flopped with another chromosome. And they're glued onto each other so that when you're trying to divide these and divide your genetic material 50-50 to be haploid, it's very challenging to end up with the right number of chromosomes when you're dividing them. You could have them be normal or balanced, but you very frequently have unbalanced gametes as a result of the division and the alignment along the metaphase plate. You can also have Robertsonian translocations. These occur more commonly in the acrocentric chromosomes. These are chromosomes where the centromere or the center of the chromosome is close to one end or the other. This is more common in chromosomes 13, 14, 15, 21, and 22. And our most common translocation is actually the flip-flop between chromosome 13 and chromosome 14. Essentially, you end up with one giant chromosome that is glued together. And very often the remaining kind of nubbins from the short arms are lost in this, and you end up with 45 chromosomes instead of 46. And again, it's very challenging to divide your DNA 50-50 from a gamete source, sperm or egg, that has a Robertsonian translocation. People that have translocations should undergo genetic counseling. They should notify their family members, because if they're balanced, they may have other balanced family members, and the family members should be tested and should be counseled as well. People with translocations can try on their own. They could try to conceive and do prenatal genetic testing, things like CBS or amnio. They could do IVF with PGT, that's pre-implantation genetic testing for structural rearrangement, or they could use donor gametes, either egg source or sperm source that does not have the translocation. Again, other causes of multiple miscarriages. Let's talk about the autoimmune component. This is your antiphospholipid antibody syndrome, and recommendations are to test for antibodies from the American Society for Reproductive Medicine. We also see autoimmune causes of ovarian dysfunction, such as autoimmune thyroiditis. People that have anti-thyroid antibodies have an almost 4 times relative risk of miscarriage compared to people that do not. We also know people with autoimmune thyroiditis tend to undergo menopause a year or 2 earlier than those that do not have autoimmune thyroid disease. And we often see autoimmune disease not otherwise specified that can be associated with reproductive outcomes that are less favorable. Antiphospholipid antibody syndrome is an acquired thrombophilia. About 5 to 20% of individuals have this. And these antibodies confer a marked increased risk, almost up to a 10% risk of miscarriage. There was a study in human reproduction, and 20 patients with multiple miscarriages and anti-cardiolipin antibodies who had declined treatment. Of them, 90% of them had multiple miscarriages, and 94% again occurred in that first trimester. Early pregnancy loss is quite common. We think that this is due to vascular insufficiency, potential thrombosis of the uteroplacental interface, and impairment of the trophoblastic function. Just going again back to some basic embryology here. So we have maternal blood flow, and we know that it's important that the uterine spiral arteries can feed through to allow the developing pregnancy to invade and grow. Antiphospholipid antibodies have a multitude of effects on the trophoblast. They can inhibit the villus cytotrophoblast differentiation and extravillus cytotrophoblast invasion into the decidua. They can induce syncytiotrophoblast apoptosis, and they can initiate a maternal inflammatory pathway on the syncytiotrophoblast surface. And so this all impacts the ongoing development of the embryo, the maintenance of implantation, and the feeding of nutrients to the embryo. We know that antiphospholipid antibody syndrome is based on 1 clinical criteria being met and 1 laboratory criteria being met. Clinical criteria are a history of either thrombus, whether it be arterial or venous, and some sort of poor obstetric outcome. This could be 3 or more miscarriages less than 10 weeks, a miscarriage after 10 weeks of a morphologically normal fetus, or a delivery less than 34 weeks, due to severe preeclampsia or placental insufficiency in a morphologically normal fetus. If we think about laboratory components, this requires 2 positive tests on 2 separate occasions separated 12 weeks apart. And one important thing to know is this needs to be done outside of pregnancy because the presence of beta HCG can falsely create the positive reaction for anticardiolipin, anti-beta 2 glycoprotein, or lupus anticoagulant antibodies. And so we want to make sure that we have trended the beta HCG level down to negative and then tested the antibodies. Now, if you have a patient that's difficult to capture and you're testing with the presence of beta HCG in the system, and these are all negative, then they are very likely to be negative. I worry more about a false positive if we're testing in the presence of beta HCG. ACOG recommendations for treatment of patients with diagnosed antiphospholipid antibody syndrome is anticoagulation. You're going to use heparin or low molecular weight heparin plus aspirin 81 milligrams. And we actually continue this through 6 weeks postpartum. And this results in an approximate 50% reduction in miscarriage rates or pregnancy loss. This is helpful to maintain blood supply to the developing pregnancy and maintain that blood supply throughout the pregnancy. Moving on to our next cause of multiple miscarriages, we're thinking about anatomic abnormalities, and these can be assessed either with HSG or saline zona histogram. Additionally, other modalities such as direct imaging from laparoscopy, hysteroscopy, or MRI could be considered as well. When we think about MRI versus hysteroscopy or laparoscopy, these are often confirmatory tests or even something that you're doing diagnostic as well as therapeutic treatment. So you're treating the anatomic abnormality if you have a high index of suspicion based on hysterosalpingogram or sonohysterogram. Now, 2D versus 3D, that depends on your equipment, your availability, your radiologist's opportunity for getting these images or your ability to do the 3D rendering. 3D does give finer detail than 2D, but most abnormalities can be visualized in 2D. One thing to note is that Mullerian anomalies are very commonly associated with renal anomalies because of the development of the Mullerian tract. And so the MRI can allow for renal assessment at the same time as Mullerian assessment. We go back to the embryologic origin of the uterus. The Mullerian tract develops in two separate tubes, left side, right side. The uterus forms with the urogenital sinus and it creates the UVP or uterovaginal primordium. And it is a fusion at midline and then dissolving of the midline fusion to create the lumen of the uterus. And so when we're talking about Mullerian anomalies, we need to understand if this is an abnormality of fusion, an abnormality of the dissolving of the midline structure to create the lumen, or an abnormality of both. If we think about our traditional form of congenital uterine anomalies, this is our AFS historic diagram. You can tell it's historic, it's in black and white. There is a new multi-page practice bulletin. The long and short is you can have fusion defects, dissolving defects, but these do not comprehensively categorize the full spectrum. Everything is quite variable. When we think about the most impactful components for miscarriage, it's actually the dissolving defects. And that's because that tissue at midline that is meant to dissolve is generally fairly avascular. So if an embryo is implanting here, it is not getting good blood supply, and that can be a significant risk for that to not have an ongoing pregnancy. So when I think about septums, a paper-thin septum concerns me much more than a big, broad, chunky, well-vascularized septum. If we have something that is arcuate or broadly subseptate, that concerns me less than this very, very thin septum. Now, the septum definition has evolved over time. We talk about the fundal indentation and the angle that we're looking at. Anything that is greater than a centimeter is considered a partial septum. Anything less is considered arcuate or normal. And then we also want to understand the external contour, which is a limitation of hysterosalpingogram. Hysterosalpingogram will tell you about the internal cavity anatomy, but it will not tell you anything about the myometrium. So I would caution anybody of taking a patient directly to hysteroscopic septum resection if the only imaging that you have is hysterosalpingogram. You could very easily puncture the fundus with your surgical instruments and lead to perforation and intra-abdominal entry. You want to understand the serosal contour and indentation component. And bicornea is defined as anything that is greater than a centimeter. Again, hysterosalpingogram gives us some information. It tells us if we have a normal endometrial cavity, if we have a fundal indentation suggestive of either a broadly septate uterus or an arcuate uterus. I cannot tell you which one this is because I can't tell you the depth of the indentation. This one could either be a septum or bicornuate, and similarly, the final one could be as well. We don't know anything about the external myometrial contour, so these should be a red flag to you that you need to assess the myometrial contour further, whether that's via MRI, saline histogram, or even just a standard 2D ultrasound in the transverse plane trying to assess the fundal indentation can give you additional information. If all else fails, you can do combined hysteroscopy, laparoscopy, and use laparoscopic guidance for hysteroscopic resection if desired. If you're planning that type of approach, make sure that you're turning the light source down on your laparoscopic source so that you can transluminate and make sure that you are not creating a very thin fundal contour. It helps guide your surgical approach hysteroscopically. Again, 3D imaging can certainly benefit. In this upper right corner, we're seeing the ability to measure the fundal indentation. We can also assess the outer serosal contour compared to a hysteroscopingogram where we don't have that information. These are both the same patient with the same anatomy. And then hysteroscopic approach down center, you can see that septum is present and is being resected. We know that septum resection can certainly increase our ongoing pregnancy and live birth rates. It's one of the very clear surgical managements that can increase live birth. Metroplasty, so if you have a bicornuate uterus, that is not recommended. You shouldn't be trying to cut out the midline structures and sew them together to create a functional singular cavity. That is not a benefit, and that has high morbidity. I don't think anybody is currently doing that. That's more of historic nature. Now, other thoughts are about acquired anomalies, things like polyps, fibroids, adhesions, synechiae. These are a little less clear, although I certainly have concerns about synechiae causing a failure for embryos to implant or increasing the risk for miscarriage if an embryo tries to implant at an area of synechiae, because these, by definition, again, are fairly avascular, very similar to a septum. If we talk about our formal guidelines, if we talk about the board answers, these are not things that have been clearly delineated to increase your risk of miscarriage. I worry more about cavity distorting fibroids, so submucosal or large intramural fibroids that are acting like a speed bump on the inside of the uterus, distorting the endometrial cavity. I worry more about them impacting implantation, impacting delivery. So if you can't have a vertex fetus because you have a giant fibroid that is impairing fetal rotation, I do not think of them as being significantly impactful for miscarriage rates. However, if you're doing an anatomic assessment and you're finding these abnormalities, it's hard to convince a patient not to want to surgically optimize their anatomy and treat polyps or synechiae. Myomectomies certainly are an extended discussion between the patient and the provider about the pros and cons of undergoing a myomectomy, especially for an intramural myoma, if that's necessitating cesarean delivery for any subsequent pregnancies. Things that we think about from a reproductive endocrinology standpoint, if I'm doing an assessment and I'm finding these fibroids that are distorting the cavity, again, I'm discussing with a patient, talking about their symptoms, saying, you know, there's no solid data indicating that this is the reason for your multiple miscarriages, but I think normalizing your uterus is only going to improve your obstetric outcomes from a delivery complication rate, bleeding, and then also from a gynecologic management of heavy menstrual bleeding or bulky sensation. Moving on to our hormonal or metabolic causes, recommendations from the American Society for Reproductive Medicine are to test for hyperprolactinemia, Thyroid abnormalities, which I mentioned earlier, autoimmune thyroiditis has increased rates of miscarriage. And then also testing for poorly controlled diabetes with a hemoglobin A1C. We also know lifestyle factors, which are part of the hormonal component, can impact our miscarriage rate. So cigarette smoking causes vasoconstriction and can increase our rate of miscarriage by almost twofold. Even secondhand smoke has an impact. So very often I have patients say, oh, well, my partner smokes, but I don't. I say, well, that's as bad, if not worse, if you're exposed to it secondhand. Excessive alcohol or heavy drug use, things like cocaine, also a vasoconstricting agent, can increase your rate of miscarriage. Excessive caffeine can increase miscarriage rates, and these are high rates, so excess of 3 cups. And when I'm talking to patients, I'm having a discussion about what they're drinking. You know, are you having like 3 monster drinks per day? Are you having like a quadruple espresso or a simple cup of coffee? And we know that increased rates of BMI, unfortunately, have lower rates of live birth. This is one that is very challenging because patients have a hard time discussing BMI and diet, and everybody's working very hard on it. But that is one component to lifestyle that patients can control and can optimize. It's quite challenging because very often when people are dealing with the grief of multiple miscarriages, there's kind of food therapy and self-medication, especially for people that are already at a predisposition for that. But it's an important component that we should counsel patients to optimize their health and lifestyle. Now, things like vaping, those are less clear, but I certainly am concerned about vaping impacting implantation and maintenance of pregnancy rates, so I counsel all patients to discontinue that, similar to tobacco as well. Things that are controversial. So looking at all sorts of autoimmune components or clotting components beyond the lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein. Those are all controversial and so not recommended to be tested. Fibroids and polyps, again, not recommended that we look at these as routine screening, controversial, but certainly going to be things that you're going to find as part of your assessment. PCOS, insulin resistance with a normal glucose levels, and luteal defect. So ASRM actually came out with a recent practice bulletin talking about luteal phase deficiency. A single progesterone level does not well delineate luteal phase deficiency. There's no good test for that. A traditional definition is a luteal phase less than 10 days. So it's more of a clinical diagnosis than a laboratory diagnosis. And progesterone is released in a pulsatile fashion. It may vary up to 20-fold in a single 24-hour period. So there's not necessarily a good progesterone level versus a bad. It's dichotomous. It's either ovulatory or anovulatory. Now, if you're checking progesterone in pregnancy and it's low, that to me is a red flag that something is not going well in the pregnancy. It generally is the red flag of abnormalities, not the cause of abnormalities. That said, very often luteal progesterone is given or exogenous progesterone in early pregnancy is given. There's no solid data supporting the benefit of this, although there's also unlikely to be harm from it. Other things that are not routinely recommended are infectious disease screening for things like BV or yeast or gonorrhea chlamydia. Certainly if someone is symptomatic, you're going to test them and treat them for things that are symptomatic, but this is not something that should routinely be done. There's mixed data and certainly controversy amongst the reproductive endocrinology field about DNA fragmentation and impact of that on miscarriage rates. As of right now, ASRM is not recommending it for male infertility assessment, for multiple miscarriage assessment, but there definitely is ongoing discussion about this. And the main thing is tidying up lifestyle components. making sure that they're not exposed to environmental toxins to the best of their abilities. And no smoking, no vaping, no recreational drugs, limiting caffeine and alcohol, eating a healthy, well-balanced diet, maintaining a normal BMI, not sitting in a hot tub all day, every day. So optimizing general health and well-being is important for both egg component and sperm component. I always say to patients, general health and well-being is reflective of reproductive health, and reproductive health is reflective of general health and well-being. So try and be as generally healthy as possible. Now, there's research on the psychological component and whether or not they're impacting uterine receptivity. It's a very interesting study, but there is data saying that TLC and regular frequent care actually does increase delivery rates, but we don't know exactly why that is, so there's not a great test for this. And then the alloimmune testing is not currently recommended. Things like natural killer cells, cytokine testing, HLA typing, other antibody testing beyond the antiphospholipid antibodies that we've mentioned. The long and short is, most people do go on to have a successful pregnancy. These are our Kaplan-Meier curves showing patients with recurrent miscarriage. The one on the left is the ones that have had at least one live birth after their first consultation by patient age, and you can see each of these age categories. Clearly, younger patients have higher probability of achieving live birth than patients of advanced reproductive age, primarily because of the decline in oocyte quality and quantity with age. And then the one on the right is the live birth based upon how many miscarriages had been experienced prior to presentation. So the more miscarriages that you have, the more likely there is some sort of underlying pathology that may or may not be able to be corrected. So we do see that their ultimate probability is lower than those with fewer miscarriages. But the message that we should be taking out is there's hope. There's hope that even though you've had multiple miscarriages, the statistical probability is greater than not that you're going to get to a live birth, as long as you can have a tolerance to hang on, and what I call for patients, ride the ride of trying to get pregnant. Unexplained multiple miscarriages, you can have patients trying their own. You could add adjuncts to it. That could be things like aspirin 81 milligrams heparin or low molecular weight heparin. If you're adding these adjuncts on, including progesterone, I think it's very important to tell patients in unexplained multiple miscarriages, there's not solid data saying these are now. Most of the time, they're not going to hurt. Now, if you have a patient with a subchorionic hematoma, you probably want to stop anticoagulation, or someone that has a bleeding disorder, or someone that is actively bleeding. Or some patients, if they're doing vaginal progesterone, they'll get irritation or BV or yeast. You may want to hold that due to side effects, but most patients tolerate these very well. Again, if I'm prescribing these, I'm completely blunt about the fact that there's no solid evidence supporting this. But have I prescribed it? Yeah, I have. It's not common, but it is a discussion of pros and cons with patients. Again, talking about the TLC, the counseling, we know that our study showed psychological support with weekly medical and ultrasound exams and visits with a healthcare provider, and reducing strenuous activity led to a marked increase in live birth from 36% in a control group to 85% in the treatment group or the TLC group. Of course, everything interpreted with caution. This was not a randomized study, so definitely subject to bias, but something that's easy enough to do. I tend to have my patients in weekly for ultrasound, a checkpoint sooner if they're experiencing any concerns, and I try to test them for pregnancy as soon as humanly possible, around 4 weeks, then repeat the beta HCG a couple days later, repeat it a couple days later just to make sure it's trending in the appropriate direction, and also to do the ultrasound as soon as possible so I can diagnose whether it's a clinical intrauterine pregnancy loss or a biochemical pregnancy loss, because I think that's important for meeting criteria and getting our definitions. Additionally, if we do have a loss, I always recommend testing for products of conception. I think of euploid loss as being very, very different than aneuploid loss. Aneuploid, biologic selection, something wrong with oocyte, sperm, or both, or embryo. But euploid losses are much less common, and they make me think of more systemic issues or unexplained multiple miscarriages. We can also do IVF with pre-implantation genetic testing for structural rearrangements for anybody that has a known genetic translocation or abnormality, ring chromosome or something like that. Now, IVF with pre-implantation genetic testing for aneuploid, hey, do you have the right number of chromosomes or not? For a young patient with unexplained recurrent pregnancy loss, unlikely to be helpful. Can it reduce your rate of aneuploid loss? Absolutely. Can it reduce your rate of euploid loss? IVF is not going to cure euploid pregnancy loss because you're getting pregnant. You're getting pregnant with a genetically normal embryo. There's nothing magic about me doing IVF and putting a genetically normal embryo in the uterus versus biology getting a genetically normal embryo in the uterus. It's about the adjuvants and the support that you're going to do after pregnancy is achieved. You could do IVF if you needed to from an infertility standpoint, but it's not going to treat the multiple miscarriages with euploid loss. Again, use for PGTA based on the American Society for Reproductive Medicine, similar pregnancy rates and miscarriage rates in patients doing pre-implantation genetic testing for aneuploidy. Now, you can get pregnant faster because we're removing the aneuploid embryos from the cohort that we would transfer, but we're still trying to understand how to best treat this unexplained component, and we're really lacking in good scientific studies telling us what to do. I thank you for your time. I know that everybody has participated. I'm seeing a little bit of questions popping into the corner, but I thank everybody for their time over lunch here locally and then afar. I'm hopeful that we can have more webinars and help educate everybody and have good dialogue, even though it's virtually, moving forward.
Thank you, Dr. Maas. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. The first question is DES still relevant and possible?
I would say it's very uncommon that we're seeing DS now in our reproductive age patients. I'll occasionally see it in someone that's using a donor oocyte or donor embryo, but most of the DS exposure is no longer of reproductive age. So it's still something to have on your differentials, still something to have in the back of your brain, but I would say it shouldn't be the first component that you're thinking about.
The next question is, if someone has had 2 miscarriages, would you recommend they come to you directly, or do you recommend doing work at the OBGYN office?
I think that really depends on your basic environment and what the OBGYN's preference is. So some OBGYNs feel very comfortable ordering this testing. They have the availability of doing saline histogram, 2D or 3D imaging. Others are not as comfortable with that, and they want to send them over to a reproductive endocrinologist, and it definitely is part of the bread and butter of what I do every day, all day. The nice thing about patients in my facility is with unexplained recurrent pregnancy loss, I have the ability to do ultrasound very, very easily. Basically, a huge chunk of my day is ultrasound. So I can have a patient call, get them on same day for ultrasound, which is very convenient, versus at a general OBGYN office, it can often be much more challenging depending on what your resources are.
Great, thank you. The next question is, can you please explain again about why IVF doesn't help with the euploid issue?
Yeah, so IVF with pre-implantation genetic testing allows us to delineate what is genetically normal and what is genetically abnormal, so euploid versus aneuploid. But if someone is having euploid losses, if I'm putting a euploid embryo in their uterus, there's something else that's contributing above and beyond just the genetic component of it, whether it's the anatomy, whether it's antiphospholipid antibodies, whether it's something unexplained, that's 60% unexplained. It's something beyond that that IVF itself is not curing. Now, IVF can help me sort. It'll remove the risk of aneuploid loss, because if we're doing the genetic testing, I'm removing those from the cohort of embryos that you could potentially transfer. So it does help us get to pregnancy faster by eliminating embryos that would not have resulted in pregnancy or would have resulted in aneuploid loss. But I can't reduce euploid loss with IVF and pre-implantation genetic testing for aneuploidy. Hopefully that makes sense. It's a complicated one.
It is. Thank you, Dr. Maas. That was our last question. Thank you, everyone, for today's webinar, Recurrent Pregnancy Loss. If you have any other questions, please, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Reproductive Care Center, and Dr. Maas, thank you for joining us and enjoy the rest of your day. Thank you, Dr. Maas.
Thank you. Very nice to meet everybody. Take care.